And these are almost frightening to consider the implications of this. But I had spoken previously to somebody who'd worked in the pharmaceutical industry as a vaccine regulation, Susan, and she had mentioned something that has stuck in my head. And it seems that what you're saying here fits. No one is responsible and no one is accountable if something goes wrong. Is that about
Yeah,
accurate?
that's exactly what I'm saying. And if you want a bit more evidence, or it's going to be circumstantial evidence, but if you think about how long it takes for, from the point of, with a medicine that someone thinks there's a problem to the point it actually reaches a disaster and, there's a public inquiry. If you take the Cumberledge inquiry, I can't remember the timescales off the top of my head, but it's got to be 10 plus years between the products being licensed and them having to be stopped or severely limited. In the UK, that was a report that was published in 2021, I think, over an inquiry in 2019. But it highlighted the number of years over which it took for someone to actually take responsibility and say, no, that needs to be stopped. And the swine flu vaccine in the UK in 2009 was another example. It took 7 years, I think it was 2016, before it was debated in the House of Commons in terms of damages for people harmed by that vaccine.
So I like to do hindsight thinking, and I like to ask hard questions about what was happening. So the MHRA and people who have been pushing forward with the vaccination program would argue and say that at the time when we were developing vaccines to try and save lives, there wasn't time to do all of those assessments. And they had to just move on getting it out there. Okay. So, using your expertise in regulation, suppose you're in the middle of the war, you're running out of munition, you don't have the time to test and see, the soldiers just need weapons on the battlefield. What do you do?
Well, that happened a number of times. There would be a specific operation where there was a need for some new munition or an existing munition to be used in a new way. And it was possible to qualify that particular application very quickly based on very limited evidence, but only if there were strict limitations on its use. And I'll give you an example. When you carry something in a helicopter is a bad vibration environment, and vibration's bad for explosives. So you would only be allowed to fly that, whatever it was, for one flight, say, because you didn't have any data that would let you do any more than that. Whereas if you did a full-scale 5-year qualification program, you might be able to carry it for 1,000 hours in a helicopter, multiple flights. It's the same here in medicine and the COVID vaccines. I don't have a problem with them licensing something based on very limited data for very limited applications under strict limitations. And why on earth? They knew what the profile of age susceptibility to COVID was and how it rose or decreased exponentially the further down the age groups you went, so that under about 70, you weren't, I can't remember the exact figures, but you weren't at significant risk from COVID. You had to have comorbidities as well. Why on earth did they start rolling out to lower and lower age groups, still based on very limited data? I just don't get it at all.
This is a very important point and something that I think, as I said, I had always argued for targeted vaccination, which is that we knew the at-risk group, we knew it was comorbidities, we knew it was age, we knew it was obesity. You target the at-risk group. So what were you thinking when you saw the rollout to the whole population? It started to go first. They did target it first. But then it's almost as if we've got enough vaccines. Let's just vaccinate everyone. How
Mm.
how how would that decision have been made in the context of the MOD?
It wouldn't, frankly, because it goes back to partly what I was saying earlier, that I was personally responsible to the Secretary of State for Defence. I mean, he could have overruled me, but I wouldn't have suggested it. And there was a separate regulator who would audit the decisions I made and made sure that they were sound. And I don't see how that decision to roll out to younger age groups, given the evidence about the risk from COVID and the limited data from trials on the vaccines, could have justified that.
Give us an analogy in the context of the military. What would be the analogy for what happened with that rollout? So you didn't have enough time to test the munitions, and then what? You just decided to give it out and transport it no matter what with no regulations? Would that be the equivalent?
I can think of two possible ones, and not that good. I mean, it would be, in terms of what I had licensed something for emergency use in a particular theatre, the soldiers on the ground would either have to stick to that, and there was a procedure where they could actually take responsibility themselves, take it off me and have it themselves. They could effectively do whatever they were able to justify through their operational command. Because I'm not there, I'm not under fire. They're the ones in the line of fire. They need to be able to make urgent decisions like that, and there was a procedure for doing it. The other one might, in terms of how do you extend the rollout based on limited data, well, I suppose you might be able to say, well, you've licensed it for this, therefore carrying it in a lorry or something might be no worse, even if we hadn't said it was okay. I don't know. We haven't got as good an analogy as I think.
So I tell you why I was thinking about it, because the emergency use authorization was probably equivalent to what you said, where the
Absolutely.
soldier in the field could make the decision to do whatever he wanted, but it was his responsibility if there was a problem. Is that about accurate?
No, the temporary authorization, what you called emergency use, was the same as what I called they were called urgent operational requirements. We would approve those based on limited safety evidence. That's equivalent to a temporary authorization. What I'm saying is that in the field, in the theatre of operation, the military chain of command could take responsibility themselves. It would be a bit like, I suppose, MHRA giving it temporary authorization, and then you, a medic in a hospital, deciding that you're going to go outside of that.